It looks. Pain.
I'm sure it was. I have some friends who have lived in and Philly. Let's go this way.
Yeah, I think that the nice thing like with these is that like it's just close to everything.
Yeah.
It's like 2.5 hours to Baltimore.
It's very different than here.
Yeah. Like an hour from
So
Hey, how's it going?
How's it going?
It's good. Yeah. It's some research stuff. And for around this, we said it yesterday. Oh my gosh.
Yeah.
guys want to get started? Finish on time, hopefully. So this kind of concludes our fracture talks. There's just 2 of them. But we're going to talk about clavicle and scapular fractures. Okay, talk about clavicles, and then we'll talk about scapulae. So clavicle fractures. Some of the stuff is some basic stuff. Really, what I wanted to kind of focus on for this is more surgical technique, actually, because there's not a lot on indications. We'll talk about indications for both, and then some technique pearls, and then feel free to ask questions as we're going through this. Location-wise, 80% or so are mid-shaft, and really that's defined as basically from the coracoid or around the coracoid to the medial 3 centimeters or so. So it's kind of a large area, but most of these are mid-shaft. About 15% are distal, again, right around the coracoid area, and 5% are medial. Generally, at least in my mind, the medial, like sternal end, unless it's a true like clavicular head fracture, I kind of lump those in with shaft fractures as far as indications go. So these are unlike orthobolts and everything, but absolute indications. The only real 2 that I would say are open fractures or true skin tenting. The skin tenting is a little hard. If the skin is still mobile over the fracture and it's just a little pointy, I wouldn't really call that skin tenting, unless you're looking for a reason to operate on somebody. And then vascular injury as well, because the vasculature is literally like right underneath the clavicle. So this is usually a big deal. Obviously, this is like the subclavian artery or vein. And you need to fix it in order to stabilize a vascular repair. Relative indications, I forgot to put this on here, but multiple injuries, even if it's like if it's a non-displaced clavicle fracture, that's one thing, but if it's displaced at all and somebody has lower extremity injuries or a contralateral injury, I would lean towards fixing it, because in my mind, if you fix a clavicle fracture, and I'll always try to go along with my plates, I'll let them weight bear immediately. I mean, if it's an isolated injury, probably not, because they don't have to, but with multiple injuries, it allows them to mobilize and weight bear basically immediately. The other ones are greater than 2 centimeters of shortening, 100% displacement, or comminution. Comminution, or Z deformity, is shown in this picture. These are all based on some of Mike McKee's data, and it's kind of been become sort of dogma, but this is really what people have studied, and this is where a lot of our research comes from, are these numbers. So this is really what I actually use. The other thing that I think is important when you think of the clavicle, it's really the only bony attachment to the axial skeleton, right? Obviously, there's musculature and everything that'll keep the shoulder in place, and you can do okay with a clavicle fracture that goes on to a non-union or heals shorten. But you have to think about this, like if you're doing things in this area, you're your whole strut to do that is basically through the clavicle, right? The shoulder, the scapula is mobile on your thorax, but the clavicle is what gives you that length. So if you have somebody that's shortened 2 centimeters, or they go on to a non-union, you have to think that your lever arm is going to be affected. So for me, if I'm kind of borderline on somebody, I'll just get bilateral x-rays and just measure them. I think that's the only way you can really measure them. You can't measure how shortened this one is because it's all out of plane and everything. So if I'm in doubt, like if somebody came in with this and it's a young active person, it's like, all right, great, we're going to fix it. But if it's something you're not really sure about, you get bilateral clavicle x-rays and then just measure it. And if they're shortened more than 1 centimeter or 2, I have a pretty low threshold to fix those. Other reasons to operate. So this is, again, from Mike McKee. That's probably where most of the good data comes from. These are randomized controlled trials from Canada. But if you look at shaft fractures, again, we're mostly talking about shaft fractures right now. Their data showed that a displaced shaft fracture has about a 15% non-union rate when treated non-operatively, as opposed to a 95-96% union rate with surgery. So, that's like a 10% difference. That's not like moving the world necessarily, but they also found that people with surgery had improved strength and improved overhead endurance. And then even the people that went on to heal, 10% of them went on to a symptomatic malunion. Again, these are usually people that were shortened. The other side of this is if these things go on to a non-union, it is a dinky ass bone. Like it is not an easy non-union surgery to do. And especially if you're shortened and you have bone loss, your options are pretty limited. You have to take autografts, so you're taking like iliac crest and you're trying to rely on 2 different bone graft junctions to heal. So for me, if it's somebody that I'm worried about or very active patient, something like that, I will push them towards surgery because I think that, if you can get through that early phase and you go on to heal, it's a lot better than these that don't go on to heal down the road. Okay, so talking about techniques here, this is really just my own bias. And you guys have probably seen a whole bunch of different things over the years, but there's a couple of different possibilities here. So superior plating is what most of us do, most people have seen. And the real reason for that is the superior clavicle is a subcutaneous structure. So it's very easy to get down to the bone. And the hardware removal rate is technically a little bit lower as opposed to anterior plating. If you're talking about anterior plating, you really have to take down or at least come underneath the deltoid insertion. So it's a little bit more, has the potential to be less soft tissue friendly if you're doing anterior plating. And then also traditionally, they do have a higher hardware removal rate. And then there's dual plating. So this is kind of been in favor probably the last 10 years or so. I honestly think that this is just a thing that trauma guys like to do to like flex because it's like, ooh, look, I'm like bending all my plates and I'm putting 2 plates on here. Really, if you look at I think I might have a study in here in a little bit, but if you look at the data on this, there is no change in union rate for dual plating versus single plating. But there is a lower hardware removal rate, which seems like it's around 10% as opposed to somewhere in the 20 to 30% range when you're talking about these pre-contour plates. And the real reason for that is because you're using smaller plates, right? You have 2 contoured recon plates that are like 2.7 plates or 2.4 plates as opposed to using a larger, more robust 3.5 LCP plate. So my preference is either superior plating with my preference is when we're plating, I almost always will try to get an anatomic reduction if there's, somewhere in the 3 to 4 fragment range, and I think that I can lag it. I try to make that decision ahead of time, and I'll try to lag it with either 2.0 or 2.7 screws. The real reason for that is that I think sometimes when you're bridge plating here, you can have pieces of bone that are no longer attached because there's deltoid attached to a piece and it's like way the hell out there. And when you're missing chunks of bone, like especially on the inferior surface of the clavicle, I think those are the people that go on to non-union or have are very difficult to reconstruct if they do go on to a non-union. So I'll very much lean towards trying to fix these things anatomically. Lag screws are the best technique for getting the strongest compression across a fracture site. If it's like truly destroyed and there's a bunch of small pieces that I know I'm not going to be able to lag, then I won't even touch the fracture site. I'll just go on either side of it, pull it out to length, and then put a plate over the whole thing. I don't nail at all. I think I've got a slide on nailing in a second, but so for me,
That's pretty rare.
that's pretty rare.
That is- So funny.
I've bridge plated twice. Well, never mind. Once in practice, once in residency or fellowship.
Do some primary,
Yeah, yeah. It's pretty rare. I mean, that's out of like, I don't know, 50 or 60 or something. So I'm not doing that very often either. I do think what the key to that is that if you are going to be bridge plating, you really should not touch the fracture site at all. And I think when I have seen non-unions, I think it's people that open up the fracture and then all the pieces are now devascularized. And then they're like, oh, well, there's too many little pieces. I'm just going to throw a plate on top. So then you're fixing out bone in an area, and then there's a bunch of missing bone in the middle, and they go on to a non-union.
in those cases. Size fragments. And you should,
Shorten.
short. That's what I'm trying to argue. So seeing those fracture goals had the entire surgeries. Instead of trying to direct jack them out to let exactly out to the side. And purposely. Out, you can ask the electrical basis. Just on side of the requirements of that. You should get some element of lateral. It flags switch across those two pieces. Process so there's a problem in the middle. You need a set for 7 years of short.
So for me, in general, this is again not an absolute, but for me, plating for the vast majority of men, I do a pre-contoured superior plate. I think this is actually the old striker plate. I've really gone to using a Synthes plate. You can get like 4 2.7 millimeter screws in on either side pretty easily through that plate, and it's very robust. So that's the Synthes stainless steel, low profile V8 clavicle plate. But this most of the time is fine. And I'm fine using this because essentially it's a 3.5 LCP plate. So with males, the hardware removal rate is not as high. So it doesn't seem to be as symptomatic, and it's a nice robust plate. For most females, not all females, but most females I've gone to dual plating. And again, this is more just because of hardware removal rates. And the bone is smaller. So using a 2.7 and a 2.4 plate, I find that I can get it onto the bone and they seem to fit a little bit better. So this is how I've been doing most of them. You can certainly just slap a 3.5 pre-contoured plate on a female as well. again, I just think that they tend to be a little bit more prominent, my experience. So setup wise, some of these pictures are, but the way that I do this, so I go supine. I think this is different than most shoulder surgeons out there, but this is, I've done it every way, and this I think is the easiest setup, and it makes drilling and putting your screws in super easy. So I go supine, but what I'll actually do is I go supine. You guys might have all done one of these with me at this point, but I'll put a rolled blanket, but you like basically underneath their scapular spines, and then another one under their head. So what it does is it basically will kind of jut out their clavicles a little bit and then extend their head a touch. And it makes it really easy. You don't really have to work around the head at all when you're putting your drill in and screws in. And then I'll also do a little bit of reverse Trendelenburg in the bed, again, just to help with exposure wise, so you're not kind of looking on the side. So what I've really gone to over the last probably year is just using a regular table with a fluoro extension to the diving board table. I think this is super easy. You can turn it, somewhere around 90, and then you can have C-arm come in from the head if you're doing that, and then they can just rotate it back and forth and they're out of your way. Or some places like Farmington don't have that. So I'll use a flat top, OSI flat top table. And then if you're doing that, don't use any arm boards, and you actually have the C-arm coming from the other side of the bed, and they can tilt back and forth to get your tube used. And then I actually don't prep the arm in at all. So these are some older pictures for where I was before, but I'll usually just tuck the arms so they don't fall off the bed, and then I just square it out. It takes like 30 seconds to drape and prep. It's very easy, and I've never had any problems not being able to pull the arm out to length or something, or the clavicle out to length. But this more or less is what I'm doing. I have in over the whole thing. And then this is just a picture showing you can get your two different views very easily, either with the flat top or the fluoro extension diving board. I used beach chair for probably the first year and a half, and it's harder to get your drill in there. It's harder to get x-rays if you're using a T-Max bed. So I've done this, find it very easy, but again, that's just what's worked for me. Approach wise, so I'm a little, I think this matters a lot. I think that people assume, oh, the clavicle, it's just like a subcutaneous structure, so you can get to it pretty easily. But I'm pretty nitpicky about this. So what I'll do, make a long incision. Really the hardest part to get to the clavicle is lateral. So I'll make sure that you're kind of pointing essentially to the divisor's point. So if you need to get to the posterior aspect of the distal clavicle, you've got good exposure there. So it's a little bit more posterior than what you might think. I'll take, just like we do normal stuff, I'll go through skin and then bovie straight down to the clavipectoral fascia. I don't spread or anything. I want it to just be one straight tissue plane. Once we find that fascia, then I'll make flaps, both more posterior, but a little flap anterior and then a posterior flap. And then we'll have basically the clavipectoral fascia and the periosteum sitting in our wound, and then I'll feel where the fracture is, and then I'll cut with the bovie straight down to bone, one longitudinal sleeve, and then peel all the way around at the fracture site, and then I try to leave the rest of the tissue on at either end. That gives you really good exposure, and then it allows you to have this robust clavipectoral fascia to repair over the top of the plate when you're all done. I've been happy with that. I haven't had any wound breakdowns personally, but this is a wound that is prone to breaking down just because you've got so much tension on it from your back skin meeting your front skin. Cool. One slide on nailing, because I've never done this, but it's out there. Have you guys seen it? Have you ever nailed any clavicles, Bob?
Done it in the lab.
Really?
Certain fracture patterns that actually are evident. Ones which capture fractures.
No.
So most pediatric fractures are not interested in tissue. Mostly worse knee shaft fractures. no. So, in a highly displaced pediatric fracture, that includes if they're into a fracture, can almost never get the back screw across it. And so, the patients are again, every extender to the secondary, actually, no fracture something kind of like regurgitated. But if you plate those, that's the other thing that you like. I've seen them on pediatric, but maybe younger people that have a displaced transverse fracture. They try to get compression with just the thing to spar.
Yeah.
I mean, like
It's not a straight bone.
no, exactly. So I think you will see these, and so what I've done in those is that I actually have a reduction plan, which you guys have probably seen. I can probably call it a reduction plan where you can put a screw on one side, you put a screw on the other side. It's a clamp that actually attaches to those screws. You can actually compress them to where the screws. You probably have seen the trial guys. So I got one of those and I
They're called
it's like
Young blood.
yeah, something like that.
so
Use it for, like,
Traverse surgery, you can prepare depression. That's one fracture I'll do it, so I'll place two anterior screws.
Oh, and then plate them down.
Get compression across it, and then I'll take a super blade, it's a way to
Cool.
know that you're not just going to do the blade, but I think Neon is really.
I just don't do that. I mean, I've never seen it. I mean, complications are pretty bad when they do happen, but if you look at the data that's out there, which is not great, there's really not much of a difference between doing this, other than having actually a lower complication rate, which is just from hardware removal. There's a lower rate of hardware removal with nailing.
There's a way that you go in kids, there's a pretty slow technique, Jake does it, where he goes medial to lateral, and so he uses advancing nail.
No.
He uses like, the same thing with physical, like, actually that. Make a small little incision right at that C joint, make a drill hole entry site, and then under floor, I'll basically, kick the advancing nail out laterally, and then manipulate it by rotating it to the upper bit of it to the lateral fragment, and then clip it, and then pulls the advancing nail out. 6 or 8 weeks or something like that.
Cool.
So there are some tricks out there for. Depends if you look at the pediatric hospital.
Yeah. So distal clavicle fractures, this is a little bit of a different beast just because of the instability of essentially stability is based on whether the CC ligaments or an equivalent are intact. The most common is the type 2 fractures where the CC ligaments are out and the medial part of the shaft is superiorly displaced, and then the lateral part of the shaft or whatever's left is still attached with the AC ligaments. If you look at these are bad actors generally. So if it's displaced or if you're in these type 2 categories, the union rate's low. It's 64% versus 95% if you fix it, based on the randomized controlled trial in Canada. Hardware removal rate is higher, again, mostly just because the lateral clavicle is a little bit more prominent. That also is probably in this study falsely elevated because a lot of these were fixed with hook plates, and you can imagine those have to come out, so the hardware removal rate is going to be higher. The other thing here, compared to shaft fractures, if you do go on to a non-union, a lot of these are actually not as symptomatic. So just because there's a fracture distally, if it's not too displaced, you can watch it. And if it goes on to a non-union, a lot of these people actually do okay. And then if you're going to fix these, you should fix these acutely. So a couple different fixation things here that I'm going to kind of breeze through. So hook plates, I never use these. The only time I use this is if there's a concomitant coracoid fracture, because then I can't fix around the coracoid. So I've done this twice, and they work. People don't like them. They're stiff after you put them in until you take them out. And then obviously it's a second surgery. Probably the biggest issue for me is that we did a series of these we looked at a series of these in fellowship, and like 30% of them go on to some sort of erosion in the acromion from that. I mean, it's like a spike that sits right underneath the acromion. So it has to be somebody that's reliable, that's going to come back, and you have to take them out somewhere in the 4 to 6 month range. But I would not leave these in for longer than 6 months. Other options, so you can just plate it alone, but again, the bone distally is not good. So you're really just relying on these screws to stay in the bone to keep that fracture intact. So generally, I'm an advocate, and I think most shoulder surgeons would be an advocate for augmenting with the coracoid as long as the coracoid's intact to some degree. So there's a couple different ways of doing this. You could do the old Bosworth screw, which has pretty high complication rates. So nobody does that. That's just a single screw from the top. So I would not do that because, again, it's a mobile joint. You can use a button or a dog bone. You can use an anchor. There's a system, I can't remember the name of it right now, but where you basically drill in an anchor. It's pretty easy to do. But again, coracoid's relatively narrow. So I really just find the coracoid and just pass sutures underneath it. I don't think it's very difficult to do, and I don't have to worry about there being a big hole in the coracoid for the rest of this person's life. Or you can acutely put a graft around there, which I haven't done. I usually have just been doing it with sutures. I'll use one tape and one high fiber wire and go through the plate. One through the plate, one around the plate. These are just some fluoro shots. If you're using a button, you can drill through the plate, and this is essentially just a tightrope, and then cinch it down that way. Cool. I'm going to talk about scapula fractures. You got like 15 minutes. So again, there is not a ton of data on fixing these things. So I'm going to talk a little bit about indications, classification, that kind of stuff, and then a lot more just about surgical technique, specifically for scapular body fractures, because we don't really see a lot of these. Not exactly the world expert on these. I've done 2 scapular body fractures in 4 years. So feel free to chime in, Bob, if there's anything else. I didn't include your paper on the plating on like plating using the whatever the 2O shafts. Yeah. So we probably should talk about that though. So imaging, I'm just going to kind of cut to this. Like, you got to get a 3D CT on these. A lot of the measurements you can certainly make on 2D images, that's fine, but you're not going to, especially if you're considering any sort of surgery, you got to get a 3D CT, because otherwise you're just not going to get a good idea of where everything is. And then you obviously subtract the humerus and the clavicles so you can see everything really well. As far as looking at these, again, I'm mostly talking about kind of like scapular body fractures, glenoid rim fractures, that kind of stuff is sort of a different beast. Scapular neck fractures, there's the concept of the floating shoulder. Again, this is a concomitant clavicle fracture, AC joint injury, as well as a scapular neck fracture. In my mind, a real floating shoulder is where the entire scapular neck is fractured, as you can kind of see in this image. And those, again, those are bad actors if you have 2 of these, because the entire shoulder girdle is no longer attached.
Just at that point, defining what a scapular, a neck fracture is that the superior aspect of the fracture has to exit at the superior aspect of the scapula. So that's a neck fracture. So that fracture line exits the medial aspect of the scapula, that's a body fracture. So sometimes that can be using so when you get fluid, then what it truly is just it's a big body fracture that someone has that's high. So the place to actually look at it, so like in this one here, you can see that there's a fracture that goes medial to the scapula. That it's just defining whether or not where that exits, that lateral. So that was,
This also exits
right, so
that way.
understood. But if that was not exiting that direction, it was just basically a straight cut across the top. A lot of times that can look like a neck fracture, but the reality is it's actually a body fracture.
Yeah. Again, I think that's another reason to get a 3D CT, because it's really hard to tell. Yeah, for sure. So acromial fractures, these are relatively uncommon in non-reverse patients. You know, when the rotator cuff is intact, these things can actually heal. When it's a true acromial base fracture, I mean, I've only seen this twice. One of them was treated non-op that went on to a non-union. The other one I just fixed. So I've been fixing these. There's so much deltoid attached to that. So I would consider that if you see a fracture like this, I would consider fixing, especially if it's displaced, just because I think there's so much load that's being seen on there. Oh, really? In a native? Interesting. Yeah. And it doesn't get talked about as much, but this is sort of, again, one of those bad actors that I would consider fixing earlier. This is the Eidelberg, basically Gauss modification of the Eidelberg classification. These are more glenoid fractures. I think this is kind of worthless. Yeah.
I have a question. Do you?
Yeah.
With these scapular body fractures, I think I saw you once get an MRI. Do you get an MRI every time to look for cuff tears with these?
I'd say that if I'm concerned, yes, partly it's because these people can come in with them. So what happened is they're either weak because they've had a palsy, when they're scapular burn because of the injury, or they've had contusion of the muscle, and the muscle causes somewhat like the muscle is completely numb. Then what they'll do is they'll present in 6 or 8 weeks and then just doing this. And so I don't get them initially on MRIs if I'm considering treating it conservatively. But if they're the 6 or 8 week back and they're person to get their exam, then I will, because I want to make sure that I'm not missing a buffer.
Yeah, I've actually done that exact same thing with somebody. I got an MRI because they were 6 weeks out and super weak, but it was the same thing. It was just muscular.
Muscle, because
Yeah.
blood muscle, and then probably it's from contusion muscle or some contusion.
So I wanted to talk about scapular body fractures here. So this is probably why these things don't get fixed that often. To some degree, the results of non-operative management are decent. They're not great. But if you look, it's actually probably somewhat similar to the clavicle literature, other than the fact that these things rarely go on to a non-union. But the real reason is fixing these things is a bear. It's hard. I mean, it's not easy to get to the scapular body. If you do it relatively early and you kind of have a plan, it's not too bad. But again, it's not as straightforward as just incising over the clavicle and finding the bone and fixing it.
Even I'll be honest, that's obviously a common body fracture. Even an isolated back fracture,
Yeah.
it's because all the muscular attachments that are.
I think the neck fracture might be harder.
You actually get the reduction.
Yeah.
It's a struggle.
And it's like moving in 4 different planes
You
too.
have to, it's a lot of like shooting. Also, depending upon the windows, not operate. I don't know if you're going to want to get out.
Yeah, a little bit. Yeah. So a couple lines here. I actually started to use these a little bit more because at least when I was training initially, people were like, oh, it's a scapular body fracture, and that was it. But there is some data to support that if you are violating some of these principles, then people don't do as well. So a couple of these lines, lateral border offset. So you're basically taking 2 vertical lines between the lateral extent of the proximal or the superior piece and the lateral extent of the distal piece. You can see this well on that 3D image there. If it's displaced more than 2 centimeters, you have to think like the head is now medialized in relation to the origin of the rotator cuff, right? So your rotator cuff function is going to be affected by this because you're no longer going to have that lever arm. So lateral border offset, again, this is essentially shortening of the scapula.
That's like, if you see there, it's the lateral. Yeah, and that's the simple. Instead of trying to say, oh, it's 2 millimeters, it's 3 millimeters, it's whatever, 2 centimeters, whatever. It's lateral for the base of the lever, then that person's got to figure out all
The next 2 are translation and angulation. If you look at these, these will probably go on to heal. The problem is, how is the scapula now sitting on the thorax? And if you have severe angulation or translation, again, these are other reasons to be thinking about fixing these, so that you don't have to deal with a malunion takedown later on because they're having scapulothoracic problems. Monopolar angle, this is the most studied measurement out there. So this is where a lot of this comes from. But essentially, you're measuring from the superior pole of the glenoid to the inferior glenoid and then to the inferior pole of the scapula. Normally, this is about 35 to 40 degrees. If it's less than 20, or I think it's actually 22 degrees, that means that the glenoid is now facing more caudal, and these have been associated with worse function when treated non-operatively. So operative versus non-operative, like true studies, there's basically nothing out there. So a lot of this is just meta-analysis data. Really, you can find pretty good outcomes with both modalities. So essentially, we don't know. Some of this is anecdotal. A lot of this data comes from Peter Cole in Minnesota. One of my good friends trained with him. And I'll tell you, he fixes a lot of these, and he fixes them acutely, and he essentially equates them to clavicle fractures. He feels like the time to union's faster, the mobilization's faster, and they have better overhead function and motion if he fixes them acutely. I haven't really gotten on board with that, but he's fixing like, I don't know, 20 a year or something like that, which is crazy. He's at Denver Health. Yeah, there's no control. Exactly.
There is a large series of patients that was treated with the scapular fractures. Years ago.
Yeah, I can't remember.
I consider a lot of patients to utilization, investment offset actually, which is basically this large cohort of non-operatively treated patients driving on their but that's what I used to be able to kind of help.
Yeah, some of those, I don't know if it's the same study, but like the functional outcomes and pain levels are pretty low, but the range of motion actually is good. But I'm going to skip through a little bit of these. So these are some of the relative indications. Again, mostly coming from what Peter Cole is telling you, but particular surface, if you have a step off greater than 3 or 4 millimeters, you fix it. 25% of a rim fracture, lateral border offset of 2 centimeters, glenopolar angle of less than 22 degrees, and angulation of 45 degrees. So approach, what do we do here? Got to think about this. Say a little prayer before you dive in. Anterior approach, as you can imagine, if you have a coracoid fracture, you have a rim fracture, something like that, then you can do an anterior only approach. Again, if there is a body component, most of these you're going to be doing from a posterior approach. Sometimes you have to do a dual approach. But if it's a scapular neck fracture, body fracture, comminution, all that kind of stuff. And generally, if you know you're going to be going posterior, you go posterior first, and then you can go anterior if you need to. But most of the time, you don't necessarily need to. Positioning wise, these are some older pictures. I'll actually use the Tremano on the other side of the bed now. But essentially you go lateral here. Make sure everything is well padded because these are long cases. But you use a radiolucent table, either a diving board or a flat top table. And then fluoro, you can basically have them rotate over the top to get your AP view, and then rotate back to get your scap Y view, as you can see here. So approach-wise, again, we're talking scapular body fractures here. So there's the extensile Jude, which is like the traditional Jude and the modified Jude. Extensile Jude is basically you do that L-shaped, which you can kind of see here. You either take down the deltoid, well, I guess in the extensile Jude, you take down the deltoid origin medially, reflect that laterally, and then you actually peel off the rotator cuff off of the scapular body so that you can fix it. I've never done that. I think it's a little crazy to do that, but in theory, if you have a ton of comminution, you could do that. But really, the only times I would consider that is if you have a symptomatic malunion or a non-union. Modified Judea is where you leave the infraspinatus intact and you find your plane medially and laterally, and you basically kind of elevate on either side there. As you can kind of see here. So this is the modified Judea. So you can see that the infraspinatus is still intact, and we're kind of coming down to the lateral border of the scapula, and the teres is underneath here. One trick here that I've kind of, well, I was told and that I've been using when I do this is you can, when you do an anterior total hip and you like incise over the fascia of the, whatever that is, TFL or something. So you do that, you incise over the fascia of the infra. Okay, this is true like for posterior approaches, because I'll tell you, you get in there, it's really hard to tell where this actual plane is. If you go more lateral, you can kind of find like the tendon versus the muscular plane. But I've done this and it actually works pretty well. You incise the fascia, you put some like Alice clamps, and you hold that laterally and inferiorly. And then you just ride that fascial plane down, and it'll take you right to the lateral border of the scapula. And then you're right on the bone, and that's your plane. You've got the teres minor inferior to you, and you've got the infraspinatus above you. As you come up towards the neck, you got to worry about some of the vasculature, but that's worked pretty well. And then your medial approach is basically subcutaneous. Sometimes you have to come through or retract the trapezius, depending on where you are. But that is, that's right there. You can also do this more minimally invasive. This is where you basically make two separate windows, one just medially, one laterally, and you can do this in a very acute fracture and a simple pattern. So you can basically find it medially, clamp it, find it laterally, clamp it, and then fix it on both sides. As far as steps for this, so you can either retract, again, if this is not too superior of a fracture, you can actually just get some retractors under the deltoid and retract it superiorly. But again, especially with these more comminuted fractures, a lot of times you have to take down some of the deltoid origin medially, and that'll give you a good exposure of the underlying infraspinatus. As you can sort of see here, that's the deltoid that we're holding kind of medially, and then that's with it retracted. You can see the entire spine and infraspinatus there. And I've kind of gone back and forth. I basically will make both of my windows, the medial window and the lateral window. But fixing it medially will allow you to have more, or at least clamping it medially, I should say, more of a hinge medially to then move around on the lateral border, which is a little bit trickier. And then when you go to your lateral border, most of these are in this pattern where the superior fractured piece and with the glenoid is medial in relation to the lateral or the distal piece. So you really have to crank on these pieces. What I've done with this before is put a Schanz pin kind of in the scapular neck and then a bone hook around the lateral piece, and then you can kind of pull them back together and clamp them in place, just like this figure is kind of showing here. And then you plate it. So generally, plating wise, I use usually 2.7 millimeter recon plates. They have some flex to them, and that generally means one plate medially, and that will usually be kind of spun around or bent so that it can come up the spine, and then two plates laterally on the lateral border, making sure that none of the screws go into the joint. That's kind of how we do them, or that's how I've done it twice. Anyways, questions for Bob? Do you have anything else with this? I didn't talk about it, but you had looked at doing the.
We do. Seen it in textbooks, which is writing it down when I started working with scapula, is there's not great bone. B, it's a lot of dissection. So that's a huge amount of muscle that actually have to retract that. And C, there's the artery. So
Yeah.
the circumflex artery comes directly around right there. And that bleeds and retracts, you know, the kind of post. And so, it is, and when it does bleed, you really feel like you need a massive amount within the shoulder. So it will make your, what you think is in the air. I mean, you're almost there to, I mean, this sucks. And so I would say that, it's okay to come through that artery, but we need to identify it, ligate it, realize it to get it actually to get the take it. It's not, it's just that you cut it and you don't realize it, you get wrong. So what I've done instead is I started doing this just because I hated that stuff down there is I'll take two short 4-hole plates and basically just plate directly across the fracture going from the back medial to the body. There's usually enough bone, you know, where the scapula gets thin, it's much more moving. So you can get 10 or 12 millimeter, 14 millimeter screws in the medial portion of the scapula. And so you just basically stack two plates right on top of one another, two holes, sorry, 4 or 5-hole plates, or let's choose to something like that. And that's all you need. Because once you do the reduction's the hard part. On that, honestly, you probably don't even fix once the actual bone is not reduced because it locks and then you like another fracture that's like that. But it's almost like a opposite active floor part. Like you bring the head up and it clicks into place. Like you're just gonna hold it there in position. You don't really need something to get with it. And then it avoids all of that dissection along the axle and work this scapula. So we looked at it biomechanically lab that they were looking at it. It basically showed the difference between two stacked, two floor plates versus a plate that's pretty high. It's standard that runs down the column. So that's probably the only thing for me, I 100% release the delta off every single pipe. So I go in there and I don't even screw around. So just release the delta and when you're going out, just take a drill, like place 3 or 4 drill holes to the only pass through 5 wires or whatever to the drill holes, because whatever that can run with no has a problem. How would they feel in every problem and get from the culture exposure? And then I do see insurance and actually I think it really works. You know, if I help you control it.
That piece, I mean, the whole like arm is attached to that piece essentially, so it's really hard to move it. And that's the piece that you really have to move laterally. So
And then the only other thing is your approach, poster approach, uncommon a lot. And so the key with poster approach is like you know what this is saying, or medial lateral. So define the plane between the deltoid and your processus